This topic is a common topic, but it has a special reference in ECMO because blood is required sometimes a huge quantity. So there has been times where more than 5 units of blood are required per day, and sometimes even more. So it carries a special importance in ECMO circuits. So blood transfusion, when and what? Certain components of blood like the piece and certainly administered post-oxygenator, that is the platelet and the cryoprecipitate. The reason is because cryoprecipitate and platelet can cause clogging in the oxygenator tubules, so they have to be administered post-oxygenate. Now the blood products are the platelets, the packed RBCs, the FFPs, and the cryo, and they require that is needed before initiation. Now the components, whole blood. The cellular component whole blood is 45%, the plasma 55%. Estimated hematocrit is 35%. Anticoagulation is CPD, CPD2D, and CPD-DA. Stored at 1 to 6 degrees centigrade. Should be at least only 3 days old, not older than that. And it also contains platelets, granulates, and Levy factors are present. It is stored at 4 degrees centigrade up to 35 days. Indication massive blood loss, trauma, or transfusion. The filter is platelet and coagulation factors will not activate after 3 to 5 days, and donor and recipient must be ABO identical. It should be trans when and there is an active bleeding, and if you want to infuse RBCs along with the volume and clotting factors. It contains blood cells, plasma, including clotting factors and proteins, with a hematocrit of 13%. It should be given over a period of 1 to 2 hours time, with a volume of around 50 cc, and should be given through a central line. It will increase the hemoglobin, it will increase the clotting factors, it will increase the volume. And adjustment of the heparin is not adjustment in heparin doses is not required. It is to be given for a massive transfusion requiring equal to it is defined as it will have high potassium and it will get lyse on it will be released from the lyse RBCs. Acid also builds up with the stored blood. So we will need to have a soda bicarb, and citrate in the blood reduces the ionic calcium levels. Then packed RBCs. It's only cellular component. Estimated hematocrit is around 70%. Anticoagulation is CPD, CPD2D, stored at 1 to 6 degrees centigrade, good for 21 to 35 days, can be extended to 42 days. It is given for low hematocrits, and the rate of less than 20 ml per kg requires a typical transfusion. The storage anticoagulant like ACD, CPD, and CPD, they increase the acid, citrate, and the phosphate components, and the heparin binds to antithrombin 3, which inhibits factor F2, 7, 9, and 10, and the other preservatives, they interfere with the metabolism. So it has an added anticoagulant preservative. So the volume to be given is around 250 cc, and the hematocrit is around 55%. The pediatric dose is 10 cc per kg. The PEG cell transfusion, it should be transfused when the hematocrit is lower than 35%, and for VV ECMO around 45%. Now these things are also changing. Previously we used to keep VV ECMO at a higher hematocrit. Now people are doing VV ECMO at a lower hematocrit also. It contains packed RBCs with a hematocrit of 55 to 70%. It is to be given over 1 hour. The dose in small pills 10 ml per kg. Volume is up to 250 to 300 ml. It should be given through a central line. It increases hematocrit. Adjustment in heparin dose is not required. If it has high potassium from the lysed RBCs, you have to correct that. Also, the blood stored products may require to be given soda bicarb. Citrate in the blood reduces after ionic calcium level. Then RBC concentrate, that is stored at 40 centigrade up to 40 days and can be frozen. Indication for severe anemia and hypoxia. Consideration: recipient must not have antibodies to donor RBC. Usual dose is 10 cc per kg. Usually transfused over 2 to 4 hours. RBC transfusion preparation, ABO typing, screening for RBC for atypical antibodies, and cross matching. Administration: the dose of 10 cc per kg over 2 to 4 hours. Maximum 15 to 20 cc per kg. and through a central line. May require pre-medication if to reduce the allergy levels. Filter use is advisable. Monitoring, you have to look for allergic and clinical status, and do not mix with medicines. Complications, rapid transfusion may result in pulmonary edema and transfusion reactions.